Good afternoon, everyone. Thank you all so much for being here. My name is Katie Naples-Mitchell. I'm the Program Director of the Program in Criminal Justice Policy and Management at Harvard's Kennedy School in the Malcolm Weiner Center for Social Policy. And we are delighted to welcome you to our final event of the semester. This is the end of our series on the diagnosis of incarceration, the health impacts of criminal system involvement. Just want to go over again, for those who are joining us for the first time, or just because it's been a couple of weeks, how we tend to run these meetings. So as you all know, this is an open meeting rather than a webinar. We want people to be able to engage and meet each other and connect further on these issues. But that means that it's really important for us to have your mics muted if you're not speaking. So please try to observe that rule. We do want to encourage engagement and sharing of resources and try to run a very active chat. Things that Kara or the other speakers mention during this event, we will try to make sure to create links to in the chat, and those will also go on the website along with the recording of this session once that has been processed. Again, this session is being recorded, as you now know, so please, keep that in mind as you choose how you want to engage. If you have questions or comments that you want to be able to talk to the speakers about, questions in particular, please add them as they come to mind, but we won't pause until the end to kind of give the conversation its due, but we'll try to take a cue from the chat. So if you have a question, feel free to throw it in the chat whenever it comes to your mind, and then we will start back from the beginning as we take questions from the audience at the end. Of course, you can also raise your hand at the end using the Zoom function when that time comes. I think that's all we need in terms of ground rules. And so I'm going to turn over now the mic to Kara Buchanan, who is our guest moderator for this series, who is a MPA student at HKS and who also is an emergency room physician herself and has been expertly moderating this session. Thank you so much, Kara, and she'll introduce the rest of our speakers.
Great. Thank you so much, Katie. Welcome, everybody. And to those returning, thank you for joining us throughout this entire season. This is our final session, but as Katie mentioned, I'll kind of go through and show you where you can find the former sessions in case you want to catch up and watch where we've kind of covered in our conversations throughout the last couple months. So today's session will be Broken Bars, Reimagining a Blueprint for Healthcare in and Beyond Carceral Settings. Just want to make sure that I express my deep gratitude for without these three people, this series would not be possible. Sandra Susan Smith, who is our director at the Malcolm Weiner Center for Social Policy, Katie Naples-Mitchell, also director at the Malcolm Weiner Center for Social Policy, and Brian Welch, who's our program administrator. I'm very grateful to have had the creative energy and support of these three people throughout the series. So thank you again. This is my email. I've been moderating throughout the series. Please feel free to reach out with questions. If you something piques your interest and you'd like to be connected or follow up without anything, please let me know and feel free to reach out. Our series website is live. We can drop a link in the chat for this, but this is where you'll find kind of the information of what we've covered throughout the series. This is just the homepage. And we do have links on a couple of the series so far that have been uploaded to YouTube so that you can check out the full program and get to know kind of what we covered through those sessions. So please feel free to kind of explore that website. Without further ado, let's get started with kind of a review of where we've covered in the last couple sessions where the inspiration for this series came from, which was earlier this summer at the Harvard Radcliffe Institute, where we gathered some folks from across the country, great minds in this field, a lot of creative energy, two of which are here today with us as our panelists. David and Shamsher were with us this summer, trying to tackle this question of what are the 5 biggest problems we need to solve to address inequity in healthcare provided to justice-involved patients. That really became the cornerstone of where the conversation started. And we came up with 5 areas. The first was narrative and issue framing, defining the standards of care in carceral facilities for healthcare, privatization and financing and the challenges that that poses to securing healthcare in these spaces, oversight, accountability, transparency, inclusive of quality data metrics and how difficult that's been, and then challenges to alternatives to incarceration. Today, we're kind of going to be focusing on this last piece, the challenges to alternatives to incarceration, but more so than challenges, I hope that today we're kind of going to take a peek into how we should be conceiving of alternatives to incarceration in light of recent political changes and upcoming projections of where the environment might be in the next couple of years. So I'm really excited to bring together this very creative, very experienced group of panelists to kind of think about how we're conceiving of these issues and where to go from here. So I would love to introduce our speakers to you. We have David Fathi, Christine Mitchell, Carlos Martinez, and Shamsher Samra. To begin, I'll start with introducing David Fathi. He's the director of the American Civil Liberties Union National Prison Project, which brings together challenges to conditions of confinement in prisons, jails, and other detention facilities, and works to end the policies that have given the United States the highest incarceration rate in the world. He worked as a staff lawyer at the National Prison Project for more than 10 years before becoming director in 2010, and has special expertise in challenging supermax prisons, where prisoners are held for months or years at a time in conditions of near total isolation. From 2012 to 2015, he also represented the ACLU in negotiations leading to the adoption of the United Nations revised standard minimum rules for the treatment of prisons and prisoners, known as the Nelson Mandela Rules. As I mentioned, David was with us over the summer at the Harvard Radcliffe Institute, and it's been my great honor to befriend him over time and look forward to continuing to build coalitions. Christine Mitchell is the program director of the Health Instead of Punishment program at Human Impact Partners, a national public health nonprofit headquartered in Berkeley, California. She is an organizer with the Boston-based Deeper Than Water Coalition and a co-author of the American Public Health Association policy statements on law enforcement violence and carceral systems. She is a Master of Divinity from the Harvard Divinity School and a Doctor of Science in Social and Behavioral Sciences from the Harvard T.H. Chan School of Public Health. Carlos Martinez is Assistant Professor of Latin American and Latino Studies at UC Santa Cruz. He received his PhD from the Joint Program in Medical Anthropology at UC San Francisco and UC Berkeley. At UCSF, he was affiliated with the Department of Humanities and Social Sciences, and at UC Berkeley, he was affiliated with the Department of Anthropology. He received his Master of Public Health degree from San Francisco State University's Department of Public Health. His teaching emphasizes the political and health inequities structuring our society and ways that communities enact change. And his research lies at the intersection of medical anthropology, public health, and Latinx and Latin American studies. In its various manifestations, his research examines the health consequences and sociocultural implications of migrant policing, deportation, our fractured asylum system, environmental justice, and the global war on drugs. He is also the co-editor of a forthcoming book, All This Safety is Killing Us: Health Justice Beyond Prisons, Police, and Borders, Abolitionist Frameworks and Practices from Clinicians, Organizers, and Incarcerated Activists. His current book project, Captive States, Migration and Expulsion on the Carceral Frontier, ethnographically examines how the U.S. deportation regime and asylum deterrence policies have transformed the U.S.-Mexico borderland region into a zone of captivity for asylum seekers and deportees. Welcome, Carlos. I'm very excited to tackle some of those topics today. And last but not least, we have Dr. Shamsher Samra, MD and Master of Philosophy and Assistant Professor of Emergency Medicine at Harbor UCLA and co-chair of the Structural Racism and Health Equity theme at the UCLA School of Medicine. Shamsher is a member of Frontline Wellness Network, a grassroots organization of care workers committed to improving the health and systems of care through decarceration. He is the former medical director of the Whole Person Care Reentry Program and currently supports the Los Angeles County Department of Health Service in its implementation of the 1115 Medicaid Reentry Waiver. He is the co-founder of the Safe Harbor Violence Intervention Program and Trauma Recovery Center at Harbor UCLA Medical Center. Shamsher also joined us this summer at Harvard Radcliffe Institute, and I welcome him back happily to this session today. So as you can see, we have a wide variety of expertise spanning many fields and many decades. And David, you know that's coming to you next. I'm very excited to kind of kick off this idea of how we conceive alternatives to incarceration with kind of looking back at the last couple decades of this work. Let's go ahead and kind of get started where you were started, David, in the courtroom. And this immense body of work that you've been involved with at the ACLU, different cases from across the country, Mississippi, here we have Idaho, ACLU lawsuits regarding the supermax prisons in Virginia, and even to El Paso County. You have worked in many spaces. Here's a more recent case of Arizona prison healthcare, where a U.S. District Court judge made permanent an order that aims to improve the way Arizona delivers healthcare to incarcerated people in state-run prisons. Litigation has been your tool of advocacy for many years, and that's taken you all across the country, Baltimore jails included, with a recent settlement that just kind of got published earlier this year. You've also been doing a lot of work in the carceral space, just kind of thinking about working with and trying to get the word out about what conditions of confinement really look like. Here you had an op-ed about Georgia prisons and a very jarring photograph depicting just how brutal some of these conditions can be. I chose not to include the photograph, but it's certainly searchable on the internet. But you've really kind of allowed coalition building throughout your work with the ACLU, here with the kind of work with the Southern Center for Human Rights on the state of violence in Georgia prisons. This has taken the international stage as well, as we mentioned kind of in the introduction, with the UN standard minimum rules for the treatment of prisoners kind of established and inspired through Nelson Mandela's life and legacy. And the ACLU has taken this notion and really run with it, kind of issuing statements on solitary confinement and the minimum rules for the treatment of prisoners. Your work has even made, very recent headlines earlier this summer about environmental policies, brutal heating, lack of air conditioning in different spaces. And you've been a huge advocate, just kind of continuing to highlight that the greatest health and safety issues facing the prison population are some of these very preventable, humane treatment of people in conditions of confinement. You've detailed lives, living death, life without parole for nonviolent offenses, and really dove into, countless blogs and articles about just kind of how we can help understand what actually is happening behind the walls. So I love this last article that I'll just highlight because you really kind of have been working in this space for many, many years. And you wrote about kind of 50 years of fighting for the rights of incarcerated people. And I just wanted to pause on kind of what that means for you, looking back on the trajectory of all the work and all the spaces and all the people you've met across the country. And just kind of hear a little bit about your reflections on where we've come from, where we're headed. And you've been doing this work for a long time. So I'd love to hear your thoughts. Thank you.
Well, first, thank you, Kara, for that very generous and thorough introduction. It was sort of like, this is your life, and a nice trip down memory lane. As we look back over the last 50 years, there's good news and there's bad news. The good news is that there has really been a revolution in the law, and I think to a significant extent in the practice of healthcare in carceral facilities. The real catalyzing legal development was the Supreme Court's decision in 1976 in Estelle versus Gamble, when the court ruled that deliberate indifference to prisoners' serious medical needs violates the Eighth Amendment's prohibition on cruel and unusual punishment. And those principles were quickly expanded to mental health and dental care, as well as physical medical care. And the law has continued to evolve in a more progressive direction, a more protective direction, pretty steadily ever since then. And so now it's completely settled law that incarcerated people are entitled to the community standard of healthcare. There's no lower standard of care that's acceptable for incarcerated people. And courts have ruled that incarcerated people are legally entitled to treatments whose when such entitlement would have been unthinkable 10 or 20 or 30 years ago. So medication-assisted treatment for people with substance use disorder, gender-affirming care, including surgery, direct-acting antivirals to treat hepatitis C. These are legal rights that prisoners have today that they certainly didn't have 50 years ago. Now, are these principles and legal entitlements always honored? No, of course not. And much of what we do at the National Prison Project is to bring litigation to force prisons and jails to live up to their legal obligations, to close the gap between law and practice. But the progress, as we look back over the last 50 years, has been undeniable and life-saving.
Thank you. Yeah, I think it's very easy to lose sight of that when we see glimpses of where we could be, and fail to recognize sometimes just how brutal some conditions were even just a few decades back. But I know that over the course of time, now that we know that we can imagine better conditions, it's really just kind of, okay, what do we do with this history? What do we do to acknowledge that things have improved? And my question for you is, looking into the next couple decades on perspective and projecting there, do you feel hopeful? Do you feel, I know we have new administration coming in January. How are you kind of orienting your work in the next couple of years looking forward?
Yeah. Well, I said at the outset that there's good news and there's bad news. The bad news, as we look back over the last 50 years, is that the scale of incarceration in this country has exploded. There are now about 6 to 7 times as many people incarcerated in the United States as there were 50 years ago. And that, of course, greatly exceeds the growth in the overall national population in that period. On any given day, it's just a little below 2 million people if you put together prisons, jails, immigration detention, juvenile facilities. And for quite some time, the United States has had the highest per capita incarceration rate of any major country. And not just by a little bit. We have a per capita rate that's 5 to 10 times higher than those of our peer nations. So, for example, the incarceration rate here is 6 times higher than in Canada. Canada is right next door. It's a very similar society in many ways. Why do we have an incarceration rate 6 times higher than Canada? Now, the good news is that the numbers and the rate peaked a few years ago, and they've come down since then, although there are fluctuations up and down since then. But it has gotten a little bit better in recent years. And part of the growth in this incarcerated population is being driven by the brutally long sentences that we have in this country. Again, far longer than in our peer nations for comparable offenses. We have about 1 in 7 U.S. prisoners serving a life sentence, either a formal life sentence or a term of years, like 85 years. That's a de facto life sentence. And that not only affects the prison population, the number of people incarcerated, but it has as an additional consequence that the prison population is aging. And that obviously has significant implications for the medical needs of that population. I want to stop here and give other people a chance, but just to sort of preview my views, I think the most critical way to improve the health of incarcerated people is to not incarcerate them in the first place. And we are increasingly directing our work at the National Prison Project in that direction. And I'm certainly happy to elaborate on that more if there's time.
Absolutely. Yeah. I think 1 in 7 serving a life sentence is an incredibly sombering picture and very hard to visualize. But I think so many factors leading up to this. But I agree. I think we're gonna kind of loop back to kind of grasping at the roots of this issue and ideas of abolition. We'll continue that conversation throughout. So thank you for kind of getting us started just with this perspective that I know we've spoken about a little bit at the beginning of the series, of just kind of grappling with the magnitude of everything. But where do we have, areas where there is hope, where there is, a recognition of progress to continue to fuel us for the fights ahead. So thank you so much, David. And I want to kind of bring us, Christine, to the image of water, which I know has been something very, very interesting that your work has centered around. And just kind of dive into kind of from this macro perspective. One approach that your work has involved has been reimagining intervention in this system, not as much through the litigation as David's work, but really through focusing on, the idea of one area in Massachusetts, MCI Norfolk, human rights abuses in Massachusetts prisons. and the idea of water and water justice, and your work with Deeper Than Water, a coalition of organizations dedicated to exposing the rampant human rights abuses in prisons, subjected to using the lens of water justice to highlight the toxicity of the carceral state. So talk to us a little bit about water justice and kind of this more micro approach to kind of extrapolate onto the macro issue, and how that's helped you kind of reimagine ways to intervene and tackle this.
Yeah, thanks, Kara. So Deeper Than Water is a coalition that formed in 2017 in Massachusetts, and it formed after there was an expose article in the Boston Globe by David Abel about high levels of manganese in the prison at MCI Norfolk, but also in other prisons across the state. And manganese has neurotoxic effects. People inside were also feeling beyond that. People who are incarcerated were also feeling skin rashes. There were high levels of cancer, all of which is potentially associated with the toxicity of the water. And we called ourselves the Deeper Than Water Coalition because we recognize that the toxicity of prisons, the toxicity of incarceration, goes so much deeper than just the water. And so we started from a lens of water justice and trying to get clean water for folks inside. And then kind of branched into doing things like addressing, high temperatures, extreme temperatures in the summertime, addressing solitary confinement, and most recently addressing medical neglect in the prisons in Massachusetts. And so some of what that work has looked like, that is maybe more kind of closely related to talking about healthcare within and beyond carceral systems. We sent a survey in to folks largely at MCI Norfolk, but also at other prisons in Massachusetts, that someone who was incarcerated wrote and drafted about medical neglect and about healthcare inside, and collected a whole bunch of responses from folks. And we have some numbers like 79% of people inside reported having an obvious medical condition that's being ignored by medical staff. And this was important kind of in the moment that we were in, because Massachusetts contracts with WellPath, which is a private healthcare contractor to provide healthcare in the prisons in Massachusetts. They are, kind of have a monopoly across the US for providing private healthcare inside. They also have been sued thousands and thousands of times, very high levels of medical neglect and medical malpractice. And their contract period was ending in Massachusetts this past summer. And so we kind of ramped up a campaign to try to get Massachusetts to not renew that contract. And kind of like spoiler alert, in the end, they did not renew the contract with WellPath, but they did contract with VitalCore, which is another private healthcare company, which also is very similar to WellPath in terms of having all kinds of lawsuits against it. And so I think the thread kind of through all of this for Deeper Than Water as an abolitionist coalition is that, like you were saying, David, right, the best way to kind of protect the health of people inside and also to protect community health is to not incarcerate people in the first place. The state is not and cannot provide for the basic needs of people inside. And so we really need to be talking about and working towards decarceration. So abolition has always been our number one demand, with the kind of underlying framework of we also need to meet the immediate needs of people who are currently incarcerated. And so that's kind of how we're weaving together like abolition with these more conditions of confinement focused areas.
Absolutely. Yeah. Thank you for that. And I think it's just a really poignant example of starting from one space with the expertise and the scope, and then slowly kind of expanding that coalition building and garnering more folks that can kind of reach into the other spaces of just how connected everything is. And I know that David's had some experience with, Vital Core, WellPath, a lot of these private prison organizations, and it's the cut off one head, another one grows kind of feeling a lot of the time. And I think, the importance of what really has been striking throughout this series is just how many folks we do need in different spaces. And this started out, as a little bit more bringing physicians into the healthcare space, but it's very, very clear through your work. And I wanted to highlight a little bit in the public health space with Human Impact Partners that your coalition building through the organizations you've been a part of has really, tried to grab from every different arena of life, knowing that racial justice and public safety and health equity are all kind of connected to this criminal legal system and immigration detention, and really just trying to kind of beef out, where we may start in a micro space with this macro coalition building, which I know I'd love to continue to talk about a little bit later. So I just wanted to highlight Human Impact Partners and kind of, this idea of using public health research to support social justice movements and really, kind of expanding the coalition building from there. You guys, in the audience should feel free to check out the website, but it's just been very inspiring to see over time how you've started to reach into, okay, public health student networks, some local police-free schooling discussions, supporting unaccompanied youth, decriminalizing abortion, of course, has been very, very important in the news recently. And just kind of seeing that, starting from one place, really trying to just kind of garner additional partnerships over time. I really appreciated this kind of public health literature overview about COP cities and investing in public health solutions, ending the health harm of women's prisons specifically, and then some toolkits that are available on the website too about leveraging governmental public health tools for folks that are in the government to kind of, just start to really tease out where the connections are here and start to unpack and build strength across coalitions. One piece that I think has been, very, very impressive in your work is, really getting these two papers from American Public Health Association addressing law enforcement violence as a public health issue and advancing public health interventions to address the harms of the carceral system. These were, published not that long ago, just a few years back. But I think in the years since, I just wanted to kind of get your reflections on how these statements may transform activation and engagement in the years to come, now that they've sort of become established truths, at least in the fields of public health, but kind of what they have meant to you over the last couple of years and where you see kind of us being able to grow from these statements in the years to come.
Yeah, thank you. Yes, so the Law Enforcement Violence Policy Statement at the American Public Health Association, APHA, passed in 2018. That took 3 years to pass. So APHA passed it provisionally. They did not pass it the following year, and then we organized a lot to get it passed in 2018. In that statement, the policy proposals that we were making, based on public health evidence about police violence, which at the time we were writing it was not very deep. Like there was not a lot of research yet compared to how much there is now. But our proposals within that policy statement were abolitionist in nature without calling it abolition, without using the word abolition. And so we really talked about divesting from systems of policing and investing in the social determinants of health, investing in communities and community-led, community-based programs for accountability and care. So that passed in 2018. And then 2020 hit, and it was COVID, and it was the uprisings for Black liberation after George Floyd's murder. And we were like, let's go all in. We're going to name abolition in this next one. So we wrote a policy statement about carceral systems that also includes, all of the research on the harms of incarceration, the harms of carceral settings, and addresses some of the kind of key challenges that people have towards the idea of abolition or the idea of decarceration. And it passed. It took 2 years, but it passed. now the thing is wanting to see change come from those statements. So we've seen far more community organizations using those statements than people in public health right now. So like community orgs have used these statements beautifully, have pushed policy changes forward. Once we get to Carlos, the book that he's editing, there's a chapter in there about it and about some of the changes that folks have been able to move by using this statement. We also want to see public health use them. So APHA, these policy statements are supposed to drive their policy agenda, their policy advocacy. And so, you know, we're kind of organizing around them to use these statements to really define an agenda. And we certainly, the folks that I work with in the Health Instead of Punishment program at Human Impact Partners, and the students we work with, and a lot of the orgs we work with, use the statements and love the statements. And I think that they have legs to actually kind of move things. With our kind of ideal hope being that abolition becomes kind of understood as a public health strategy. Because for us, the connection is very clear, right? Like we are all about investing in the social determinants of health, public health, on board with that all the time, right? And so that is largely what abolition is in terms of investing in building up life affirming, right? As Ruth Wilson Gilmore, as the abolitionist scholar, says, building up life affirming institutions. Yeah.
Absolutely. And I love that you've previewed kind of, and we've done a separate series actually at the Malcolm Weiner Center about abolition specifically, but it's really wonderful to kind of come back to that conversation because and Shamsher, I know we'll get to your work soon, but that has been something that I've noticed a lot is the reticence in the medical communities, public health communities, to kind of move forward with language of abolition, and that there's a very charged kind of energy force field surrounding that word. And so I'm excited to kind of, we'll revisit this kind of idea towards the end of the conversation. And thank you for bringing it up, because I think it's oftentimes the public health field kind of leads the way for the medical field and the physicians to follow. And I think but that's not to say that it's, you know, where we want it to be yet. And so I think it's really powerful to kind of look at these statements as landmark moments, but really think about what the meaning is behind how we use them and who we bring into the fold with these statements. So thank you for kind of sharing your perspective on that. And I know, Carlos, you've worked in this space, looked at these kind of statements and, you know, really done some field work, bringing ethnography, medical anthropology, you know, really humanizing and centering the narratives and the stories of the lives involved in this very, very big, complex system. And your work is incredibly, you know, of depth and inspiring, and really makes us think about, you know, these borders of the United States. And I know that's kind of where your last book was kind of centered around the U.S. deportation regime, notions of the captive state, migration and expulsion on the carceral frontier, and really using some of the themes that you explored about safety and policing, deportation, and how the U.S. kind of orients to these concepts towards an exploration in the book to come, which is All This Safety is Killing Us: Abolitionist Frameworks and Practices from Clinicians, Organizers, and Incarcerated Activists, focusing on health justice beyond prisons, police, and borders. We can all look out for this book in 2025. And I really wanted to talk to you a little bit about what brought you to this book from where you've been, you know, working in the immigration detention borderland space. And one thing that really struck me that connected both of these bodies of works were your statement that communities are vilified by carceral safety systems, and you call for a radical break with reformist strategies in favor of ones grounded in grassroots organizing and abolition. And I think criminal justice reform for many years was the buzzword. And, you know, I think even in, you know, more progressive spaces, this was sort of the word that we kept coming back to is criminal justice reform. But I think you've really kind of shown the light on how reformist may not be enough unless we kind of tackle this underpinning what's beneath this idea, which is carceral safety systems and this concept of safety and safety first. And I just wanted to kind of pause to just hear your initial reflections on, safety as the theme that you've kind of spent so much of your work focusing on, and how that lays the groundwork for your engagement with putting forth kind of this idea of grassroots and abolition organization.
Sure. Yeah. Well, thank you for those opening comments and description of the work. I should clarify that the book that what you said was the first book on migration and expulsion on the carceral frontiers. My doctoral dissertation, which is in the process of becoming a book. So, but this book, All the Safety is Killing Us, is coming out in April. Actually, interestingly enough, the co-editor, Ronica Mukherjee, and I that co-edited this volume, we actually met while working both as volunteers. She's a nurse practitioner, while working in Tijuana with a group called the Refugee Health Alliance, and really forming bonds down there with a number of activist clinicians that were and continue to go to work as volunteers in Tijuana to provide care to asylum seekers and deportees. This is also work that Shamsher has done as well. So, the kind of seeds for this book actually came out of, I think, that a political context in which we're trying to really provide and mobilize care for people who are being victimized essentially by the immigration system in a variety of ways, right? This book really emerges out of a number of also other kind of conversations that we were having, and also paying attention to how the landscape was shifting, really looking at the work that folks like Christine and others with health impact partners and Police Violence Collective were doing, which a number of friends and colleagues were involved with that work. And then seeing how there were also emerging conversations around this idea of abolition medicine that were starting to circulate in sort of some of the academic medical journals as well. Particularly after the George Floyd kind of uprisings, when I think as Christine was sort of laying out, we started to see kind of a broader embrace of this idea of abolition, right? And of kind of looking beyond what Ruth Wilson Gilmore would refer to as reformist reforms, right? How do we actually move from that towards disentangling carcerality altogether and from our various systems and social services and things like that. And so we felt like, these conversations were happening, but in a very sort of limited space still, often again in academic journals. So there was a lot of buzz in those spaces, but it wasn't often reaching kind of a broader public, and certainly wasn't reaching a broader group of practitioners who might not be reading the medical journals all the time as well. And so this book really is our effort to try to bring these conversations to this kind of broader public, right? And as you said, Kara, to really frame it as a challenge to dominant notions of safety, in which we, kind of talk about here as kind of breaking with, what the forms of safety that have been placed on offer historically in this country, which, you can refer to as, think of as carceral safety, which we know are not actual forms of safety for the most marginalized communities, and that they actually are harmful in a number of ways. And as Christine said, there's, constantly growing evidence and more literature that is being produced to really demonstrate that. What I think what's really exciting about this anthology is that it collects a number of folks in various different kinds of positions across kind of different healthcare spaces, in activist kind of settings, and also in incarcerated settings. We have contributions from trauma surgeons and nurses and nurse practitioners, public health workers, from people who are incarcerated or who were deported, really thinking about and challenging this idea of safety as it's currently kind of been entangled with carcerality in all these ways, and then really practically kind of getting at how do we do the work of abolition. And I think that's what's most exciting about this book is of course abolitionism is kind of, I think for a lot of people seems very kind of distant and amorphous. And I think what we're really trying to do is to actually demonstrate that this is work that's happening already in a number of spaces, from emergency rooms to community-based settings, and work that's being done by obstetricians and gynecologists who are challenging family policing, for example. So yeah, that's kind of in sum sort of what this work is trying to do.
Absolutely. And really trying to, continue to do the very challenging work of humanizing, bringing the human narrative and threads of experience through everything. I think it's just a really powerful reminder of, again, that kind of call back to the coalition building of what the medical anthropology kind of, framework and experience can help for people and folks who see things through different frameworks, whether it's the healthcare workers receiving patients in clinics or working in the facilities, or families affected, just trying to kind of figure out what the landscape is and where we can each, kind of find a way to connect, intervene, and continue to humanize this issue to really tackle and feel more comfortable with the notion of decarceration and abolition and these very kind of overwhelming topics and themes. So I'm very excited to kind of dive into the narratives that you and Veronica have worked so hard to kind of share with us. And I just wanted to kind of ask again, how you envision the form that grassroots organizing and abolition may take in the years to come. Kind of when you have a mental image of what might be ways to organize, how does that come to mind for you? Is it more across virtual platforms? Is that in-person grassroots organizing? I know that, before COVID and during COVID, we just experienced as a country and as a global community, so many different forms of protest and organization. And now with the internet and Zoom, I'm just curious kind of how you think about what organization looks like, so that those of us in the audience can kind of think about what role we may choose to play in this landscape as it unfolds.
Yeah, sure. Well, I think, in terms of grassroots organizing and the role that healthcare practitioners can play, I mean, there's so many different examples of that already. Shamsher can definitely speak to that in terms of his work with Frontline Wellness and with the Justice LA Coalition, which I think is a really important example of what that kind of, what role clinicians can play, health practitioners, public health advocates can play in collaboration with grassroots organizations, right? I do think that there's there are so many different important roles to play for people in health because of, sort of certainly the symbolic value, but also just because we do have expertise and insights into, again, the harms of carcerality that can be really mobilized to support grassroots efforts. And so we've seen examples of that, as I said, with the Justice LA Coalition. We saw that with the Communities Over Cages campaign in Georgia, where you had a number of healthcare workers join forces with community organizations to push back against a number of proposals from the Fulton County Sheriff to expand new jail spaces there. So those, I think, are really important forms of ways that that health practitioners can be involved. And just to go back again to the book, there's also, I think, just a lot of really important examples there of ways that this organizing is happening within institutions. So one of the authors who contributed to the chapter is Mihir Chaudhary, who's a trauma surgeon, and he talks about his work with other trauma surgeons and emergency room physicians, and really trying to create and limit the presence of police in the emergency hospital settings, emergency department settings, and really also creating forms of accountability and counter surveillance, as they put it, of really seeing and documenting kind of harms of the police presence in hospitals. And so again, you see a lot of examples of this in other kind of settings where practitioners are trying to get, for example, limit the presence of police in spaces that are supposed to be for healthcare, right? So I just think that this work is going to look different based upon our different kind of positions and where we're located. But there's countless examples, and I think again we're trying to share those with this anthology that we put out.
Yeah, absolutely. And kind of help folks visualize themselves within these various ways of how mobilization could look. Thank you so much. Shamsher, I want to bring us to Los Angeles, where I know so much of your work has centered. City of Angels, also the largest jail in the world. And by that, we also mean the largest mental health provider. And I think the LA County Jail has been a site and source of so much, both tragedy and inspiration for this work that you've engaged in. And very gratefully that you've allowed me to work with you in engaging in, as I also worked in the LA County Jail Emergency Room in Los Angeles as an ER physician. I wanted to kind of take a moment to reflect on how much you have really accomplished in this space to break down some very, very strong walls and barriers, in thinking about how these coalitions kind of came to pass. And you've written very poignantly about this, both for the lay press here, when, of course, LA supervisors, noting that they run the largest jail in the world and largest mental health provider, they, said, well, you know what, we have overcrowding in prisons. We're going to vote to explore creating locked, non-correctional mental health facilities. But of course, still being locked and kind of guising this in the vein of non-correctional and what that really meant. And you've commented, these proposals risk recreating the alarming overcrowding problems that we are currently seeing in jails, and absolutely do not address any of the root cause problems that we've kind of introduced so far. I think, Carlos mentioned your work with Justice LA, and I just wanted to kind of share this with the audience that, this organization is, very much a vision with a coalition mission centered in Los Angeles County, thinking about the whole community, and prioritizing the people of the community over incarceration. And I encourage everyone to kind of look into the organization, and I'm sure Shamsher will share a little more. But you've written about this so that we could kind of learn from your experience of how you went about allying public health and abolition, and really carried out a campaign against the construction of this new jail in Los Angeles, and all the things you've learned through that campaign. I just wanted to share a brief selection from this paper about how you've reflected this unprecedented reversal did not happen overnight. A broad alliance of community organizations across Los Angeles, united as Justice LA Coalition, had shifted the political landscape. Formed in tandem with the movement for Black Lives, this coalition flipped the jail plan's notion of health on its head. Through campaign slogans, "Care, Not Cages," and "Can't Get Well in a Cell," Justice LA argued that rather than build a jail that meets the health needs of its future population, Los Angeles should not build a jail because jails can never meet the health needs of incarcerated people and their wider communities. The consultants had accepted as a given that the Los Angeles jail population would continue to grow, and Justice LA argued that such a trend represented a health crisis. So really trying to kind of help, reframe things with the help of a large coalition. I just wanted to kind of hear your thoughts on lessons from that work in campaigning coalition. And particularly, I think, as the article, does include allying public health and abolition, to speak a little bit about the notion of physicians as abolitionists and kind of how you went about, breaking through I think I called it like a force field, an energy field around that word that does kind of have a presence in the medical community as something that is a little bit like, oh, I don't know if that's my lane or not. And I know you've done a lot of work in this space, and would just love to hear your thoughts on both the campaign, the coalition, and kind of how you work to bring physicians into the space of abolition, to really use the power of, the authority, that is there, to continue to push for a more grassroots abolition approach.
Yeah, thanks for that, Karen. Thanks for bringing this whole kind of conversation together. I think, this is such an important part of it. It's just having these conversations. And I think for me personally, if we think kind of about the material kind of conditions of the society we're in for healthcare workers who work in kind of jails or reentry, and on the outside, healthcare as an institution is a huge institution, and similarly, unfortunately, mass incarceration is as well. And I think for healthcare workers, you're kind of trapped and complicit in some of the harms of two kind of carceral settings, especially if we're working amongst the safety net or communities who are served by the safety net. So a lot of this work started with really doing a couple of things. One, creating a space so people can actually create their praxis, kind of understanding of the type of care that they would like to provide and the type of advocacy they'd like to do, independent of these institutions, which, in the 9 to 5 or however many hours you're working, you're kind of subservient to. And in doing that, being able to have the structural analysis, being able to understand, do the work that really Christina's been pushing, because oftentimes what happens is even the more liberal reforms that happen, it's really focused on the hypertension, the diabetes, and all the other things, but very rarely will the carceral system or jails themselves be named as something that's harmful or dangerous. And what results from that are things that, the plans that LA County put forth, right? They were, the last jail that was built on the, for the reasons or for the stated reasons of improving mental health services. The health consultancy group that came in, they justified $4 billion to build 2 new jails to improve health. And it really took providers kind of stepping out of their usual lanes, but really just being in conversation with community individuals who are impacted and organizers to be able to understand that there's a way to hold both conversations about improving healthcare and decarceration and abolition at the same time. And how do we think about practicing in a way that is consistent with that and not so much as kind of reproducing some of the institutions that we currently have. So, I think it was the start of a conversation. It was effective in terms of stopping that new jail construction. Men's Central Jail, which was supposed to close, still hasn't closed, so work is left to be done there. But the coalition kind of organically started to think about what does it mean to be kind of abolitionist health providers? And it's not just doctors, it was people who are interested in health and really kind of a broad definition. And in 2020 or so, it was the same coalition of folks who showed up outside of a hospital after police killed an unarmed person, a patient within one of our county hospitals. It was the same coalition of folks who showed up in, I think, 2021 when a private equity-backed group was closing a hospital in the midst of a surge of COVID. So it was starting to make these connections between kind of our highly segregated healthcare system and the connections it has to the carceral system that is incarcerating people who have been excluded in a variety of ways, including healthcare. And I think it's those types of conversations and those types of connections that really happen by creating these spaces and drawing and inviting people into them. And I think it, is encouraging to, when you talk to folks who are impacted and they're able to think about ways that you can talk about improving the healthcare of individuals in jails and in prisons at the same time, talk about decarceration. Because when you bring some of these conversations to, health delivery spaces and stuff, it for some reason, people have a hard time making those connections.
Absolutely. And I know, David, you actually have been working in some litigation at LA County Jail on decarceral measures. Do you have any updates from kind of the work you're doing with the ACLU right now?
Yes, as I said earlier, we are really doing everything we can to use our litigation to advance decarceral solutions. And it's not always easy to do that because there's no US law doesn't impose any limit on how many people we can have locked up. You could have 5 million, you could have 15 million. There's no obvious constitutional provision that says you can't do that. But through creative structuring of settlements, we're trying to bring about decarceral results through our litigation. So in Los Angeles County Jail, we had a contempt motion over conditions issues where the county was not complying with some orders that had been entered having to do with conditions in the jail. And we settled that contempt motion for, among other things, the county's agreement to open almost 2,000 community beds to divert people with mental illness who would otherwise be held in the jail. Now that was just about a year ago. Those beds they certainly haven't all been open. I don't know if any have been open, and so we'll see how this works in practice. But I think it's an example of how you can use conditions litigation, well, at least when the stars are in alignment, to bring about results that go beyond just conditions, but can actually have a decarceral effect.
Yeah, absolutely. And Shamsher, kind of, circling back to, some of the themes that you brought up with, what role do physicians have, whether they're aligning with, ongoing active litigation strategies to just kind of continue to, provide the perspective of what healthcare really means, and to not let that become, just diluted into some strange warped version of what the county has said, oh, well, this is for health reasons. And I think just this selection from the paper about, the positions of passivity that may also prevent healthcare professionals from realizing the opportunity that is now before them. As David was saying, if, kind of there is mobilization and there's some litigative strategies also just continuing to layer on with the coalition building to really continue to kind of have a riptide of folks that are, along the same messaging of decarceral strategies. So I think this paper was just a really powerful way to almost help us with a blueprint for additional strategies in the future. And as a lot of your work has been, in terms of the physician advocacy space, I think, organized care is an antidote to organized violence, and engaging clinical ethnography in the LA County jail system. You've written about ethical, legal, and structural frameworks for enforcement in the emergency department, and, continually pulling in race, racism, and anti-racism, scoping review of the literature and research, just to kind of continue to align the medical space with these, medical, cultural, anthropologic, racial and racism frameworks, and just continuing to really infiltrate, a wider scope with the notions of decarceration, notions of abolition. And I think that your work really stands as a testament to how important that is to not keep the silos, so divided. And I think, a lot of this comes down to being responsive, inclusive, and person-centered. And I just wanted to share with the audience some work more recently about, really trying to continue to, humanize the narrative of folks who really are, deeply affected by the layering of clinical welfare and penal medicine, and, just the influences on health equities. So this was a wonderful piece that was published just to kind of help folks understand some of the clinical conditions and clinical, clinicians involved in how we receive patients affected by so many different systems. And my last question for you is just kind of how all of this body of work has really helped you conceive the role for physicians as witnesses, as agents and advocates, and where you see that kind of moving in the next wave of, as David was mentioning, there's these community beds opening, maybe there's some hope, maybe there's some progress, but kind of continuing to stay engaged as physicians who are, very much mixed in as providers, but also agents and witness and advocates.
Yeah, thanks for that. I mean, there's, obviously tremendous more work that needs to be done in terms of decarceration. I mean, we've had some wins, some of them, they're slowly moving. So we got to keep pushing there. But I think really the role of healthcare workers, broadly speaking, and being able to comment on, like I said, again, it's not, the jails are, I think, probably the worst form of kind of healthcare in a lot of ways, but the people are re-entering into hyper-carceral, hyper-policed, segregated forms of care that are super-carceral. And I think we have to be able to comment on those conditions and comment on how to make those connections. And the work that Carlos does in terms of telling those stories and experiences of people, and even better, creating spaces so people can uplift their own stories and experiences, kind of engaging with systems that aren't promoting health and wellness. They're probably oftentimes just providing a lot of trauma, but maybe just enough care in other cases. So I think we really have to make time and make space for those conversations.
Absolutely. Yeah. Thank you so much. Yeah. And thank you for bringing me into some of your work also, and looking forward to kind of ongoing coalition building in the years to come. I think I want to make some space for our audience questions. I just had one final thought for the group. And I think Jackie Wang in Carceral Capitalism writes, what do we make of the flowering vine that uses as its trellis the walls of the prison? And it's just this complicated visual of, we know what we know. And I think even going back to our first session of the series, where we spoke to folks from the Prison Policy Initiative about, we don't need more data. We kind of know what's out there. We always need high quality data and are happy to receive more data, but it's not going to shift the realities of what we already understand. And we can start with what we have and work from there. But we know what the situation is. And I think, I was, kind of in this vision of like the house of, carceral health. There's some days where I feel like I can kind of enter the house. I have a small room. I can do what I can to, try to make that room as welcoming as possible, set some ground rules for that space, try to treat folks humanely and share that mission and, work with the spaces that I interact with, working with justice involved folks. But at the same time, I think my question, last thing, just for the whole group to kind of respond to is, I think that I often even personally shy away from grasping at the roots, as Angela Davis would say, grasping early at the roots of this house and this system, because I worry about losing my small ability to maybe impact that small room that I've been working in. And there is some, reticence, I think, on the part of a lot of practitioners to expand and really grasp at more. Not wanting to lose the ground that we're making. And I just wanted to kind of hear your reflections on how you each tackle this notion of maybe having a micro area but where you're working in, and whether you kind of like have chosen to kind of say, okay, I have one space, I'm going to focus in this space, or are we at a shift in time where we really should be grasping into different spaces and attempting to really kind of grasp at the roots of things a little bit more along the abolition perspective. So I'd love to hear kind of from your thoughts, and then we'll switch into a couple questions from the audience.
Yeah, maybe just one quick reflection. I mean, one thing that always kind of inspires me in this question is kind of the work of the Black Panthers and their work with sickle cell disease, and really uplifting it as a diagnosis that was overlooked, intentionally marginalized because of the community that was affected. But the end goal of that wasn't necessarily just to improve care for sickle cell. It was to use it to highlight the broader injustices within the healthcare system and society more broadly. So I think thinking about it's an example of how you can really narrow focus and bring about positive changes, but as long as you're couching it in an accurate analysis and you're not kind of intentionally obfuscating, the thing, that's kind of the underlying issue but easier said than done in a lot of spaces for sure.
Yeah, kind of holding both at the same time. Yeah. David, I wasn't sure if you had unmuted to add anything.
No, I think it's obviously a really difficult and I think highly contextual judgment that you have to make, because certainly for many people working in the prisons or with incarcerated people, your access is at the pleasure of prison officials. And if you stray too far outside your lane, you could lose that access. And so I think there is a constant tension between wanting to be more, radical in the literal sense of that word, and, not wanting to lose access that allows you to do some good things, even if not everything you would like to do.
Absolutely. Yeah. Thank you for that. I think, yeah, absolutely. Christine.
Yeah, I mean, I think that grasping at the root is an essential part of public health and what public health is. I think often we talk about like addressing things upstream or primary prevention strategies. And that, to me, when it comes to a system like this, is what can we be investing in? What conditions of society can we be changing that then downstream will lead to less harm and no more need for policing and incarceration. And I think a lot, again, to bring Ruth Wilson Gilmore into the space, who says abolition requires that we change one thing, everything. And so my kind of approach to it has been like, we need to be working with people in housing justice and people in healthcare and people in education and people in transportation justice. And for each of us to kind of choose, all right, here's where I'm going to put my energy and my focus, and to maintain those connections, kind of in broad coalition.
Absolutely. And Carlos, I wanted to make space just in case you had anything to add. Otherwise, I think we have a few questions for you as well.
I guess I'll just end by saying I think abolition is fundamentally rooted in practice, and I think as folks were kind of speaking to, really the relationship between theory and practice is going to be always fundamental, and I think this is where these kinds of spaces, this kind of education that we're getting allied, along with the kind of practices, whether big or small, are going to be always kind of fundamental to the abolitionist project in any kind of space.
Absolutely, thank you. And Katie, I'll transition to you to take a couple questions from our audience.
Absolutely. So we have a few in the queue, and I know there are some more that also have been asked. We may not get to all of them. We've got about 10 minutes left, not even. But Gail Osherenko, would you like to unmute and ask your question?
I'd be happy if you just want to read it.
Sure, that's fine. No problem. We just always like to invite people to engage directly. So Gail wrote, if our county mental health services were actually meeting the need, we would not have 125 people in our county jails with serious mental illness. Are there any examples of local jurisdictions successfully providing healthcare that helps to keep people healthy enough so they don't end up in jails? I wondered if people had a positive example of an intervention that seems to be successful in reducing the jail population. And I think in some ways the LA County example is what's pending, but we don't really have the on the ground facts yet, right? But I don't know if anyone wanted to speak in more specifics about kind of what the vision is for what that's going to look like.
The vision and the intention beside at least, our little piece of it, this settlement to create the 1,950 community beds is that, people who can function in the community, who certainly don't need to and absolutely should not be incarcerated, can get supportive housing that allows them to stay in the community rather than go to jail. As I said, we will see, even for Los Angeles County, even 2,000 beds is probably not nearly sufficient. We'll see how this shakes out in practice. Settlements often, the implementation looks a little bit different than it does on paper, but I think I think number one, it's a helpful precedent for other jurisdictions to look at. And I'm confident that it will do some marginal bit of good, although I'm sure it, as I said, is not going to be a complete solution.
Yeah, thank you for that. Our next question comes from Lonnie or Lainey Graham. Would you like to unmute and ask your question?
Yeah, sure. So I heard it very clearly that we have enough data, but the general public I don't think the general public has the slightest idea what's going on inside prisons. And so that's very worrisome to me. And I was sort of hoping that the move toward oversight or more transparency might be a way of making some of this information more accessible to the general public and eventually move us more towards abolition. So my question is for the authors to comment on oversight or transparency as a step towards abolition.
Yeah, maybe I'll kick it off. I think there's a tremendous amount of need still needed in that space. I think there's a huge gap. The standards are lower than they should be compared to community standards in many cases. And even then there's a gap between the normative standard and what actually happens. And in part, that's due to oversight and probably in larger part due to lack of enforcement. And then what follows from that and needs to be paired with that is, kind of culture change, which I think is kind of a significant part of the work as well, from people providing the care, but agree with you in the sense that there's still, in my opinion, a lot more oversight and transparency that needs to happen.
Thanks. I was sort of hopeful about the new federal bill making some headway there, but I guess we'll see.
Yeah, I'll share too that part of what came back when we sent in a survey to people who are incarcerated in Massachusetts about their experience of healthcare inside. We kind of closed it with a question of what would you want to see look different? And one of the things that people who are incarcerated named was wanting some kind of oversight body that included incarcerated people for healthcare inside. So that's kind of one piece of information. The other, I think, in terms of thinking about this as a public health issue and thinking about primary prevention, by the time we get to oversight, it's like already downstream. And so, yeah, it's that kind of constant tension of like, how are we meeting the needs of folks immediately, and also, trying to prevent harm from ever happening in a way that ends with people being incarcerated.
Thank you for the question. I think we're going to move on to the next just in the interest of time. So this is more of a kind of brief technocratic question, so I'm just going to ask it on behalf of our questioner, a kilogram, which was for David. You had mentioned there are these 1950 beds waiting to open, we think, but is it your sense that none of them have opened yet?
Well, the honest answer is I don't know. Part of the problem with being director is I don't have my fingers in the details of the litigation as much as I used to when I was a staff attorney. I just went back and looked at the agreement, and I believe 1,700 of them are supposed to come online in the first 2 years, meaning by June of 25. So I would certainly expect and hope that some of them are open, but I'm sorry, as we sit here, I don't know that.
No, that's okay. And I think just a follow-up question to that, actually, I think one of the things we see in the tension between building infrastructure within the jail to improve healthcare versus building infrastructure outside of jails to improve kind of community and behavioral health is sustained funding streams. So I wondered if you could speak to that. I mean, I know there was a project in Boston that kind of built transitional supportive housing inside a formerly abandoned hotel, and built Boston Healthcare for the Homeless program, built on the ground floor a kind of set of healthcare interventions for people and services. And that model was ultimately shut down because it was run by ARPA funding. And that the same organization is now building a new behavioral health unit inside one of the county jails. And just thinking about those different priorities about kind of where spending comes from. Was that part of the kind of settlement, or is there a way to sustain the funding for these beds that have now been authorized pursuant to that?
Yeah, I mean, you're right. Sustainability is a huge issue with any of these decarceral interventions, because it seems there's always money for prison, but money for alternatives to putting people in cages seems to be much harder to come by. So yeah, that is obviously a critical ingredient of any kind of serious decarceration strategy. Is where's the funding going to come from after the first 2 years, 3 years, whatever.
Okay, we have one more question on the horizon from Kareem Morsi. Kareem, would you like to unmute and ask your question?
Yes, hi, thank you for giving me the platform. Thank you all for talking today, and I really do appreciate the conversation on abolition. I think I can agree with you all that it's definitely the necessary point that we're at now. So the question I have is that I guess I'll just kind of read aloud. So I think part of the issue is that there are a lot of reforms that are presented like with the cover of violence prevention or, improved crisis response that still have so much of a police component to them. And it actually becomes a situation where police have been able to amass and implement a variety of really invasive policing technologies like shot spotter cameras, even carceral access to prescription drug monitoring programs, which there's a great book that came out recently about policing patients by Elizabeth Chiarello. But essentially, the question I'm trying to get at is, we know that police aren't helpful to improving these goals of public health, but so many federal grants require their involvement, so much funding towards crisis response it requires that you work with police. And understanding also the trends, right, the broader political trends of building militarized cities to train law enforcement in more militarized tactics, how what does that future look like, realistically speaking? And I'm speaking as a professional doing policy work in this space, but also as an advocate who's trying to, push against militarization and carceralism, especially when we're dealing with millions of dollars in funding that sometimes those are the groups that you have to work with. So yeah, loaded question, but.
Great place to end, though, for us to kind of tie these threads together. I don't want to call on anybody at random. Does somebody want to start us off?
I just dropped in the chat the report that Kara had pointed to earlier, which is about kind of a public health case for not building cop cities or these militarized police training facilities. That might be of interest to read to you just for some of the research that's in there. The APHA policy statements also kind of get at this question of working against these kind of like reformist reforms and instead focusing on the ones that lead us towards abolition.
Yeah, I'll just add, I mean, it's tough, having done some work in the violence intervention space, definitely know that that's where a lot of the money comes from. And I think it's a mix of being intentional about checking some of those harms as much as you can. And sometimes it involves bringing the right people. I think Christine had mentioned earlier in terms of, individuals with histories of incarceration or incarcerated individuals and oversight bodies, but how do you kind of bring that into the fold when you're rolling out these programs to kind of change the culture of your program? But there's obviously a lot of complexity there.
I was just gonna add, I mean, I think again, as Christine was sort of pointing to, I mean, this is fundamentally where the role of health practitioners is really going to be so important in being able to put forward experience and expertise that shows the harms of policing, that demonstrates it, that shows the growing evidence around it. And so, folks just need to be part of these kinds of coalitions, I think. And that's again, to challenge sort of the meta narratives of safety and of crime waves and hysteria and that kind of stuff. And I think that's where, yeah, again, health practitioners and public health advocates have a big role to play in that.
Absolutely, yeah. And I know, Katie, I know we're wrapping up on time. I'm sorry if we didn't get to all of the questions, but feel free to email, reach out. And I just wanted to say thank you all so much for being a part of this last really, I think, like pinnacle of the series, where we've kind of come to the point of exploring all of these different themes and topics and covered just the magnitude of how big this problem is. And I know the first part of the series was titled Just How Bad, and I think we've really gotten there. But I think that this tonight for me meant also we can't shoulder this alone. And we absolutely have to employ everyone that we have in our corner, lawyers, doctors, public health advocates, researchers, ethnographers, medical anthropologists. I think it's just a testament to how we cannot do this in silos. And I'm really grateful that we got a little bit of a kind of snapshot of each of your life's work so far. of where you've kind of taken us and where we can really continue to coalesce and continue to do this work together. So I am very, very grateful to each of you, Carlos, David, Christine, Shamsher. Thank you for being here. Thank you to our audience who's just been so enriching throughout the entire series, and stay tuned for an email follow-up to just kind of have a way to keep in touch as an audience for upcoming engagement together. And thank you again. Appreciate it, and happy holidays.
Thank you.
Thanks, everyone.
Thank you all.